Having done these, we can look at mobility testing. Just come towards me a little bit this way, Bev. Thanks. And we can look at flexion and extension, but we've also got the quadrants that we can test here as well. And we've got 4 quadrants. There are 2 flexion and 2 extension quadrants. If we look at the flexion quadrants for mobility, we have a inner flexion and an outer flexion quadrant. Sorry, excuse me a second. It's right the way round here. It's saving me back. Drop the bed down a tad. And we'll do these quadrants. So, the first quadrant we'll do will be flexion, medial rotation and abduction of the tibia. So I'll just stabilise the femur and grind, if you like, the tibia into abduction as I maintain the medial rotation. And I'm looking for an abnormal ovoid of motion as I do this. And I'm picking up clanking and grinding as I do this, which would indicate an instability, an articular instability, possibly meniscal. For the other flexion quadrant, I'll produce lateral rotation and adduction. So I'll be doing this movement, like so. And I'll show you both of those on the other leg so you can get a look at both tests from another angle. So we'll flex, medially rotate and abduct, and flex, laterally rotate and adduct, like so. For extension, we can extend, laterally rotate and adduct. And the easiest way to do this is to fix the leg to the bed. Just move that one over there. Fix the leg to the bed, which you can't see there. Laterally rotate and adduct this way. And I'm looking for that normal ovoid of motion. And the other extension quadrant is medial rotation and abduction, like so. These techniques can obviously be used for treatment as well. If I find that I have a hypomobility, either from the physiological movement testing of flexion and extension or from these quadrant tests, then I need to check the arthrokinematics. And these will be checked in about 30 degrees of flexion. Just move up the bit a tad. Thanks. And there's no reason to use stabilisation for the testing. I'll just wedge a foot up against my leg this way, stabilise the femur and draw the tibia forwards and backwards, looking for a normal glide. Now, from these tests, we should be able to tell whether we've got a ligamentous instability, a meniscal instability via the quadrant test, or whether we have a hypomobility. So this will lead us on to naturally to treatment. In the knee, we actually have 3 parts of the range that we have to consider. The neutral part of the range, where there is a glide but no conjunct rotation. The ends of the range, where there is a glide with a conjunct rotation, and the extremes of the range, where there is no significant glide, and it's a hinging or a rocking movement of the bone with the conjunct rotation. So if we are gliding the tibia, this is a concave surface. And to treat this, we need the leg in some degree of flexion. And you really need a reasonably sized sandbag to bring it into that position. So if I want to treat, say, flexion in this resting position, then I will stabilise this, and this should be flexed to around about 30 or 40 degrees, stabilise the femur, come onto the tibia and glide the tibia posteriorly. And I can grade this depending on whether I'm trying to get range or to decrease pain. To regain extension, rather than draw the tibia upwards, I'll stabilise the tibia on the sandbag and push the femur backwards. Now this is a convex surface, so a posterior glide will produce an anterior osteokinematic and induce extension at this segment. For the ends of range, where I have to also accommodate the conjunct rotation and the glide, this has to be considered. So if we're looking at extension now of the knee, then I'll stabilise the tibia, make sure that the tibia is laterally rotated in this position and stabilise it in that lateral rotation. Medially rotate the femur, like so, and now I can produce that glide of the femur backwards. Again, I'm not mentioning this, but don't forget the hold relax techniques before you try and do this. To regain flexion, and I'll show it to you on the other leg, the end range of flexion here will bring the knee up to its flex position, ensure that we have the medial rotation, come onto the tibia, and then we're going to glide the tibia backwards on the femur. So this hand is simply stabilizing the femur while my left hand is inducing a posterior glide. For the extremes of these ranges, then we're going to forget the glide and make sure that we're getting the rocking movement. So we will have the leg up and produce the medial rotation for the flexion here, and simply hinge the joint by pushing back into flexion. And this is very similar, and it can be changed into a quadrant scouring technique simply by adding the abduction scour. That's the extreme range of flexion. So having treated flexion in that manner, we need to look at extension, the extreme of range of extension. So again, no glide involved in this. It is simply an extension technique with the conjunct rotation added. So we will laterally rotate the tibia, medially rotate the femur, and then simply hinge up. Now, it's very important, particularly with this technique, that the hold relax technique is utilized every time and routinely. Otherwise, you'll stretch nothing at all and get no increase in range. And this last piece of range is vital for weight-bearing extension. It's often the range that is not regained in these patients.